Jyothi Anup. She is a highly accomplished Phaco surgeon and refractive surgeon par excellence with more than 2 decades of surgical experience. She has surgically trained many ophthalmologists, myself included, and she has an exceptional ability to teach surgical steps. Over to you, ma'am.
Thank you, Nilufar, for that introduction. My topic is about day-to-day problems while doing Phaco. So whatever Dr. Shobha and Dr. Anjana told about the problem, I'll be showing some of the problems. So in the beginning, it is very tempting to take soft cataracts, but phacoemulsification of soft cataracts are not that easy. As you can see here, I am struggling. If you go deeper, then you may end up with a posterior capsular rent. If you go near the periphery, you may end up with a solar dialysis. Whereas this learning carouseling, this is a very, very good technique. You can see the Phaco is finished in a minute. But you need some practice to do carouseling, and a good hydrodissection and multiple rotation of the nucleus is mandatory. Here I am still struggling with the soft cataract. So sometimes you end up with multiple problems. As this was an elderly patient, cornea is not that clear, pupil moderately dilated, he is not at all, he was not cooperative, and a hard cataract. So I decided to convert into, I started giving, I'm planning to give subtenants. Learning subtenants is a very good thing that at any stage of your surgery, like when you do topical, you can any stage of surgery you can convert. And this is a very hard cataract. I have not emulsified deep, and my cracks are very superficial, as you can see. I haven't cracked the posterior plate. So I am struggling with the separation, and finally I ended up with an intact posterior capsule, intact posterior plate, and somehow I prolapsed a part of the nucleus and I could finish the case. So when you attempt a hard cataract in the beginning, the escape route is your rhexis. You make a large rhexis so that somehow you will escape. Otherwise, either you may end up with a solar dialysis or a PCR or a corneal decompensation. So when you do hard cataracts, repeated injection of visco is also mandatory. That will save your cornea. Otherwise, you will end up with severe striate keratitis next post-op. And by the time I finished this case, I had another issue. There was a conjunctival ballooning, which I managed with a small nick in the conjunctiva and squeezed out all the saline with the cotton bud, and that usually comes with a posterior location of the incision. As you can see here, I have cut the conjunctiva in the beginning. So this is another hard cataract, not very old patient, but it was hard cataract. So I have buried the nucleus well, and I could separate the posterior plate. So the Phaco went on well. But here I thought I finished the case. I loaded the IOL. I'm just showing the IOL loading. And here I faced another trouble which I have never faced in my life. My trailing haptic got stuck between the plunger and the cartridge. As I was doing a hydro insertion, I just pulled out the irrigating forceps and injected visco, and I'm cutting the cartridge. While pulling, you may break your haptic. If your haptic is broken, then you have to extend your section, explant an IOL and implant another IOL, or also you can cut the IOL inside also, but that causes severe SK, so I usually explant it by extending the section. Here I am struggling. I have removed a piece of that plastic, loosened it, still that was not coming. finally I pulled out this and I could escape. In such case, after this case, I took a break. Sometimes that is also essential before starting the next case. This was a simple soft cataract. I finished the Phaco emulsification, but I'm trying to take out the epinucleus by taking the probe to periphery. Such overconfidence act can make you end up in major problems, like I ended up with a Sonla dialysis. I inflated the chamber with a high molecular weight viscoelastic, and I was lucky to be I was able to manage it with a CTR. And when you implant a CTR, your cortex aspiration becomes really difficult. You have to pull your cortex towards the open end of the CTR. Otherwise, the cortex will never come. And this is another cataract. This is like an ideal cataract to start with an NS2, a firm nucleus. But I finished the Phaco, but this firm nucleus had, I think, some firm epinucleus too. Probably my Phaco, my hydrodissection was not adequate, was not proper. A good hydrodissection will save a lot of your time in aspirating the cortex. I am repeating the hydrodissection here. I am rotating the epinucleus with iris repositor, and it was not coming. So what I did was a modified IOL scaffolding technique, usually done when there is a PCR. I implanted the IOL and safely emulsified the cortex. And when you do hydrodissection, that after doing a proper excis, as Nilufer told, you have to deflate your chamber a little bit. You have to express out some visco, then only you get a good hydrodissection. And you should go take your cannula towards the edge of the, even under the capsule. And then, but your hydro should be adequate. It should not be over that the nucleus may prolapse also. So this was another patient, a well dilated pupil, but patient was on tamsulosin, and the pupil was dilated and cataract was not that hard. So I took the patient without using any devices. You can see the typical iris flutter here. This is an intraoperative floppy iris syndrome. So what I did was, I did not remove the probe at all. I completed the entire Phaco with the probe inside. And the probe was kept always at the center of the pupil. Otherwise, you may catch some iris. And whenever there is an iris prolapse, always check the integrity of the globe, like whether the globe is hard. If your globe is hard, express out some visco or saline. And if your globe is not that hard, then you can even repose it with the high molecular weight viscoelastic. Or this is another way. Like with the iris repositor. The iris repositor, you can gently reposit the iris back. And you can, any step, if you learn iris hooks, you can use iris hook at any step of your surgery. If you have done your rexis, then you should inject viscoelastic under the rexis margin and the iris, otherwise you may hook your capsules. And this is, in intumescent cataracts, the most tough part in Phaco is your rexis. So whenever you do a rexis, you should use high molecular weight viscoelastic to flatten the chamber, and you should use the forceps, either an Uttradha forceps. Here I am using an Uttradha forceps. Either use an Uttradha forceps or microforceps. Microforceps can that is ideal, so that you can do your rexis in an intact chamber, and you should always pull towards center. Any stage it can escape. Here I thought I finished the rexis. It was in the last step, and this is the place where it extends, at the section where your chamber shallows. It has ran off, and I am cutting it with a vanas. As this was a soft mature cataract, and I got a very large rexis done, and my rexis extension was near the section, so I proceeded with a phaco. If the extension was in the opposite side, I would not have attempted that. It can cause a nuclear drop. As my first case of phaco on a rexis escape was a nucleus drop. And while doing phaco, you should always use low flow parameters. Your wattle height has to be less, and you should not exert much pressure over the globe. So I managed it without extending. Sometimes that can extend posteriorly also. And however much ever skilled you are, sometimes that I didn't do anything. That was an Argentinian flag sign. The rexis got torn. And this is how you should extend the rexis, cut on either side, but I could not make it. So that was a clear corneal temporal tunnel here, and I am doing a superior SICS now. And as my rexis was all damaged, I implanted a three-piece sensor IOL in the sulcus. Thank you.
Thank you, Dr. Jyothi, for sharing those pearls of wisdom. Your talk truly reflects the real challenges the surgeon faces once they start doing phaco